Imagine your body's built-in purification system just completely shutting down. Suddenly, medical science has to step in and replicate the work of an organ that's usually filtering your blood 24 hours a day, 7 days a week. It's a monumental task, right? But the mechanical and biological solutions we've developed to step in when a human kidney fails are, frankly, nothing short of incredible. Welcome to This Explainer, where our goal is to demystify the physical and biological mechanisms that keep patients alive during kidney failure.
Okay, let's dive into this roadmap. To really grasp how we replace the kidney, we've got to first build our physics toolkit. Then, we'll look at how those core principles apply to intermittent hemodialysis, continuous renal replacement therapy, and peritoneal dialysis, before capping things off with the ultimate biological replacement, a renal transplant.
So, Section 1, the core physical principles. Before we even think about operating the complex machines that keep patients alive, we have to wrap our heads around the fundamental physical laws of the universe that actually make artificial filtration possible.
The very first, and maybe the most critical tool in that physics toolkit, is diffusion. Simply put, this is the movement of solutes from an area of higher concentration to a lower one across a semi-permeable membrane, good old Fick's law. In the context of our blood, diffusion is the primary way we clear out small metabolic waste products. We're talking molecules smaller than 20 kilodaltons, things like urea, potassium, and creatinine. Because these waste products are highly concentrated in a kidney failure patient's blood, they naturally want to escape across that membrane into a clean, specialized fluid called dialysate, where their concentration starts right at zero.
Now, while diffusion clears out the toxic waste, what about all that excess water? Well, that's where ultrafiltration comes in. We're essentially using a pressure gradient to mechanically force or literally squeeze excess fluid out of a volume-overloaded patient. Think of it like physically squeezing water through a filter using a transmembrane pressure gradient. It's an absolutely life-saving mechanism for patients who are oliguric or anuuric, meaning they just aren't producing urine and are severely backed up with fluid. Let's add convection and osmosis to the mix. So the crucial point is distinguishing convection from osmosis. Convection happens when that pressure gradient we just talked about drives water across the membrane, but it actively drags larger solutes along with that bulk water flow. This is huge because convection can pull middle-sized molecules up to 60 kilodaltons, things like vitamin B12 or tumor necrosis factor that diffusion simply leaves behind. Osmosis, on the flip side, is the natural pull of water from an area of lower solute concentration toward a higher one. Keep these concepts locked in your mind because our different therapies rely entirely on mixing and matching these exact physical forces. Moving on to Section 2, hemodialysis, intermittent mechanical filtration. This is where we apply all those physics we just talked about to a highly efficient external machine.
And this brilliantly illustrates exactly what's going on. Inside the machine, blood and dialysate fluid are separated by a semi-permeable membrane. High-concentration waste products like urea and creatinine move out of the blood and slide down their concentration gradients into the dialysate. But it's a two-way street. The reverse is true for beneficial substances like bicarbonate, which moves from the dialysate straight back into the plasma to help correct the patient's dangerous acid-base derangements.
To completely maximize this process, intermittent hemodialysis, or IHD, uses an absolute engineering marvel: counter-current flow. The blood and the dialysate run in opposite directions through these synthetic, high-flux hollow fibers. This ensures the blood is always exposed to the freshest dialysate possible, maintaining a super steep concentration gradient the whole time. IHD relies heavily on this rapid, diffusion-based clearance over short 3 to 4 hour sessions. And because it runs at a high blood flow rate, it's incredible for the fast correction of severe, life-threatening hyperkalemia and uremia. Objectively speaking, though, that sheer speed comes with a trade-off. Rapid fluid and solute shifts can cause massive hemodynamic instability. We're talking severe hypotension, muscle cramps, and dangerous pressure shifts in the brain. So what happens when a patient is just too critically ill to handle those rapid fluid shifts? Well, this is where we have to compare IHD with continuous renal replacement therapy, or CRRT. Because of the rapid fluid shifts we just mentioned, IHD can actually be dangerous for unstable patients in the ICU. While IHD clears solutes rapidly via diffusion over a quick 4-hour window, CRRT takes the slow road, operating over a continuous 24-hour period.
It relies much more heavily on convection, slowly adapting to fluid volume changes. This prevents that hypotensive crashing related to rapid volume depletion, making CRRT the absolutely necessary gentle choice for patients in shock or multi-system failure.
Which brings us to Section 3, CRCT, Continuous Gentle Clearance. Let's look a little closer at how we actually provide that gentle, continuous support as an alternative for our most fragile patients.
Let's move to and see how this builds into continuous veno-venous hemofiltration, or CVVH, which is a primary modality of CRRT. What is fascinating here is that CVVH doesn't even use dialysate. No way, right? Instead of diffusion, solute clearance relies almost entirely on convection and ultrafiltration. Solutes are hydraulically dragged with the bulk flow of fluid straight into an ultrafiltrate. Now, to keep the patient from dehydrating, a specialized replacement fluid is added back into the blood. Because this runs on a continuous 24-hour extracorporeal circuit, it gently clears toxins that have large volumes of distribution without ever shocking the patient's fragile cardiovascular system.
Section 4, Peritoneal Dialysis, Internal Filtration. What if, instead of relying on an external artificial machine, we harness the patient's own natural anatomy? Now, what's really interesting about this slide is how we utilize the body itself. Instead of piping blood out of the body and through some plastic tube filled with synthetic fibers, we use the natural lining of the patient's abdominal cavity, the peritoneum. A catheter is placed right into the peritoneal cavity, and dialysis fluid is infused directly into the abdomen. The rich vascular network within the peritoneal membrane beautifully acts as our semi-permeable filter. The mechanism of peritoneal transport completely removes the need for mechanical blood pumps. Instead, the whole shebang is driven purely by osmosis and diffusion. By infusing a sugary dialysate packed with dextrose, we create a strong osmotic gradient. This sugary solution acts like a magnet, naturally drawing water and waste out of the blood vessels across the peritoneal endothelium through what's known as the biological three-pore model, and right into the abdominal cavity to be drained away. It requires a really delicate biological balance since there's an inverse relationship between solute transport and ultrafiltration in this model, but it is such an elegant way to manage fluid natively.
Finally, Section 5, Renal Transplant, Biological Replacement. Rather than attempting to just mimic the physical outputs of a kidney with machines or internal fluid exchanges, what if we choose the ultimate biological solution and replace the failed organ completely?
The surgical and immunological sequence required to actually pull this off is just incredible. We can walk through it chronologically. It starts with precise compatibility testing, specifically looking at major histocompatibility complex matching to prevent hyperacute rejection of the graft. But perhaps the most mind-blowing detail is preservation. Once that donor kidney is removed, it must be flushed and stored in a specialized hypothermic, hyperosmolar solution at 4 to 10 degrees Celsius. It's a brilliant technique that effectively pauses biological time, keeping the organ viable for up to 24 hours during transport. And finally, the recipient operation takes place, fully restoring normal physiological filtration to the patient in a way that honestly, no machine truly can.
We have explored everything today, from the delicate physics of diffusion and convection to the macroscopic marvel of surgical organ transplantation. We've seen how machines can push and pull fluids across synthetic fibers, and how the body's own abdominal lining can act as a natural filter. It leaves us with a provocative thought. From mimicking microscopic convection to surgical organ transplantation, which engineering or biological marvel is the most remarkable? Thank you for joining me on this journey through this explainer, and keep questioning the incredible mechanics of the medical world around us.